Good afternoon and welcome to Ashgrove TV. Today we're going to be looking at ligaments with the aim of helping you to understand what they are, what they do, how they work and how you can recover from a ligament injury. With me in the studio today is Jay Sheridan, our senior sports therapist and rehab specialist. Welcome to the show, Jay. Good to have you back.
Lovely to be here, especially to talk about ligaments, one of my favourite things, and it's an injury I see a lot of in the clinic actually.
And I know on a previous episode we've talked about ligaments, so
yeah, we just a couple of people have suggested could we go maybe a little bit deeper into this. I think it was always my intention to come back and explain, without getting too bogged down in terminology, a little bit more what they are, what they do, because there's a lot of myths around them as well, I think, and certainly they're getting busted a little bit more in recent years. The myths with ligaments, but I tend to find people have really misconceived views about what the injury is, what their recovery time is, and I just want to get across to the audience a little bit more about how we deal with that injury effectively.
Well, the thing is, these shows are quite quick, and there's only so much we can cover in that time. And if people have been asking you about it, then it makes sense to revisit.
Yes.
So let's start with the basics. Firstly, what is a ligament? What's its job? What's its purpose? For those of us that don't know.
Well, everyone's going to say to you, ligament connects a bone to a bone. Okay. And if we keep it in them simple terms to a point, that's what they do. Okay. So if you think in essence, say if we take the knee joint, the ligaments here are going to stop excessive movement and dislocations in joints as well. They are there really to protect the joint, but to facilitate safe movement within the joint. Okay, often the injury occurs when that ligament is taken out of its natural range. Okay, so that can be, I think people know about anterior cruciate ligament, say on the front of the knee, is a classic football injury or rugby injury. Okay, seems to be one that people know. That's because that ligament has exceeded its natural length and therefore has either been damage to a minor extent or further up the chain, what we call a full thickness rupture, so a complete tear of it. So they're there to protect joints, but the geeky bit is, and this is the bit that we'll come on to later about why the rehabilitation phase can be tricky for a ligament sometimes, they're also there to tell you where you are in space and time. So when Christian's walking, how much does this knee need to protect? How much movement can you do before you exceed movement and damage it again? So we know that gets distorted, unfortunately, after serious injury, certainly a serious ligament injury. And actually probably minor injury too, will just distort the way the brain communicates to ligament areas. So they are there for us to know how much movement, how much do I need to lift this glass up. They are really the communicators of our body too. Not just muscles, the ligaments are massively important in that.
So what are some of you've mentioned like the ACL, but what other common ligament related injuries do you come across?
Well, if we stayed on the knee, you would have also the inside medial collateral ligament is another classic one as well. Other areas of the body, and I think most of our viewers must have sprained their ankle, that classic where we roll the ankle, what we call an ankle inversion. And we've actually got quite a few ligaments on the outside of our ankle actually, and there's one or two that you'll probably always injure in a severe inversion, and it's an interesting one with the ankle because they can take a long time. They could take a long time going back to the fact that they need to communicate how much weight you need to put through that foot safely.
There's a lot going on.
That communication channel is slightly altered when we have an injury down on that ankle. So they could be notoriously slow recoveries if we don't see the person quickly and also get the treatment and the rehab in place. They're likely to have recurrences of it. And of course, other areas, shoulders, massive in shoulder dislocations, you're going to have massive disruption to ligaments around the shoulder joints in what we call an anterior forward dislocation of the shoulder, which it will be, but also into the back. Lots of ligaments. If you think on your lumbar spine, and sometimes that can be missed with injury because we're going to be looking at joints, discs. We forget that there's also very powerful, strong ligaments in the lower back as well. So,
what about the elbow? Is that one that comes up?
Yes, we can definitely have. I mean, elbows tend to, that injury would be more, and we will speak about tendons on a forthcoming broadcast. So that normally tendons here I will treat, but of course there's ligaments because we're trying to stop, and you can have an elbow dislocation. They can definitely happen, and of course it's obvious in racket sports you're going to see something there. So because it's not always a tearing of the ligament in one incident, they can be aggravated through repetition or bad technique in your chosen sport, to be honest.
And is it often sport-related injuries that you come across, or can it happen in everyday life as well?
I suppose because I'm a sports therapist, I suppose a high percentage of people I treat will be involved in some activity, from either the weekend warriors, as we call them, up to people that are more elite. Yeah, I think with that sort of side of people, it's not always sport. And I think that's one of the myths with it as well. People that are in intense jobs where they're using their hands a lot, or flexion in warehouse work, they can repetitively strain their ligaments. Anybody can be walking along a road and sprain an ankle, can't they? We know, actually, going back to the shoulder joint, that unfortunately, like all of our joints over time, tends to degenerate somewhat. So because it degenerates, that also has a knock-on effect for your ligaments as well. So that's when, say, things like frozen shoulders can start in a person, when the shoulder becomes destabilised. So, no, not only sporting people, because we've all got ligaments and we all move to some extent, don't we? So
if someone's feeling something that's not quite right, what should be their kind of trigger to seek out some professional assistance?
It depends on the severity. So I suppose if we talk about the gradings of injuries, would probably relate to that. For instance, a grade 1, they go grade 1 to grade 3. 1 is classed as minor, but actually can be a little bit more tricky than that. 2 will probably have a bit of swelling with it, maybe a little bit of bruising with it, maybe some instability in the joint. So for instance, on a knee, I'll be able to move that joint a little bit more than I should be able to. And then 3 is a bit of a disaster, because somebody's got a completely torn that ligament. And that could be, remember, they're attached to a bone. So it could be coming away from the bone and actually causing an avulsion fracture. So it pulls a little bit of that bone away, or if it goes in the centre. That, you know, there's different problems for different injuries. Ironically, people will often have more pain with a grade 2 than a 3, because there's more nerve damage with a 3. So it's something to watch there. But when they become aware of it, normally, to be honest with you, I would say 90% of the time, there is an incident, there is a one-off incident that injures that ligament. But what you would look for in that person is a sharpness of pain, because there's normally a sharpness of pain with a ligament that is really quite. And remember, if they're stationary like we are now, they probably won't feel it so much. But as soon as they go to move through the joint, they'll go, oh wow, it's sharp. So normally they'll become aware of that there's a sharp pain that's probably not going anywhere, can be increased night pain. The obvious things we'll look for is inflammation as well, and then a series of testing of the joint to see whether we can move that joint more than we should be able to, or whether it's the person doesn't want to move it, because that's the other problem. Sometimes they won't let you move it either. And from there, the pathway then, depending on the severity, hopefully would be treatment and rehabilitation.
Which was my next question.
Diagnosis.
So what I kind of know the answer, because you and me have had quite a few conversations about this. And I can see out the corner of my eye one of your favourite toys. What's kind of the best way to treat and help?
Well, we'll speak about the K-laser in a moment. For that, the initial thing that every therapist should be doing, if it's a lower leg, we want to be looking at you as you get out of the chair in a waiting room, having a look. Are you getting up a little bit gingerly? You don't want to put any weight through the joint. The pain phase with somebody, then we're going to diagnose. We're going to do our testings, We're then going to hopefully be able to treat. And the treatment bit, I just briefly showed the K-laser, because it is my favourite thing to use at the Ashgrove for ligaments and tendons. So we'll probably show a couple of images for the audience, I believe. So we're seeing that in operation at the moment. So don't be fooled by the red dot. the laser's invisible. We'd be wearing glasses because the light's invisible. We need to protect our eyes from that, okay? The red dot is merely to let us know that it's working fine, almost like a little bit of a homing beacon, okay? What this person is having through their arm at the moment is such powerful invisible light, and the closest thing to it is really a plant getting light. Photosynthesis, without being too geeky, gets light and grows. In this instance, that person, and this happens instantly, and this is a really good thing with it, there's no delayed onset, it will work instantly for that patient. So their blood is now raising in hemoglobin, a nice iron-rich protein block. I know it's geeky, but that's what gets you guys better, as well as oxygenate levels of blood will also increase as well. Totally non-invasive, painless treatment. It doesn't hurt the patient.
So when there's a red light and you say the word laser, some people might think, oh, is that going to hurt?
Yes, of course, yeah. Of course, it is completely non-invasive. It can feel warm and it can feel pleasant. And actually, I always emphasise with my patients, don't be fooled because it feels quite nice that you're not being healed. You're most definitely being healed. I don't have to keep pulling you around, and why would I want to pull a joint around that's already injured? So don't get me wrong, there is hands-on you can do around the joint. I would be working on the bicep group, the tricep group, the forearm muscles here. I would wanting to be work on these as well, because I think both the laser and the hands-on gets you there together.
So the good combination.
Yeah, but I have to say, unless there's been a total full thickness grade 3 tear that may need something else, which we'll probably talk about in a bit, this will get somebody there so much quicker than I could do with my hands. Okay, and I know it sounds like a play for K-laser. We have no affinity with a particular brand. This just happens to be the most powerful and the safest on the market, so that's why we use it.
So if you were going down that route, what's a patient looking at in terms of how many sessions they're likely to need? I appreciate everyone's different, every injury is different.
Yeah, and people's budgets are different, aren't they, frankly? Some people, it's a strain financially for them. Initially, the sweet spot with it is probably 2 to 3 sessions a week. So it sounds a little heavy, that, doesn't it? But after the initial session, which would probably be about half an hour, I'd be looking for 15-minute laser sessions, because that's about the sweet spot for using the machine. Because the hemoglobins will stay up, oxygenate levels of blood can stay up, sometimes 3 to 5 days. You want to keep it topped up. It is almost like topping it up, because the danger is, if there's no intervention, no treatment intervention, no diagnosis, that ligament will get used to behaving the way it thinks it now needs to, which is damaged. And that sets a patient up for so many other problems, Christian, because if they can't weight bear so much on one side, they can't do something with this hand because of their shoulder, elbow, suddenly we start seeing overcompensation. That patient then starts to get other injuries. So it is about really channeling the energy into getting that area better so we can get them moving in the right fashion.
Is there also the risk that if someone doesn't get the appropriate treatment soon enough and they leave it too long, does that delay the...
Oh, it's happened a lot.
I
used to work more full-time in football many years ago, and it's happened a lot with knee injuries specifically, where they've been misdiagnosed. The knee's tweaking it sharp, but that patient doesn't have any excessive movement, so they're classed as being okay. Then disaster happens, the knee gives. Then we've got a full thickness rupture. Now, for any player, for any sports person, anything as severe as that, it's a very long climb back. If indeed you do get back. So it is imperative that we get that initial diagnosis, but also, what about avoiding the injuries? If I can condition people well enough, I think we can avoid them sometimes. I think that's a bit different in football and rugby and contact sports, where there's always a chance of somebody sustaining a serious ligament injury. But I think if we can condition people well enough around their muscle groups and get those ligaments sort of fired up, because of course the ligaments respond to movement as well. They're not growing like a muscle does, but they respond to movement. So it's about trying, sometimes, if you're working with sports people, trying to get them to avoid the injury.
Or if you're doing something, a job that requires certain movement, you can do conditioning around it.
Indeed, because as I say, if we touch on the fact, if somebody has got what's become now chronic, which purely means long-term situation, then you may have to look at changing a plan. Maybe this person does require surgery, although evidence would point to, say, with a knee, that anterior cruciate ligament again, the quicker we can get that surgery done, the better on a knee, if it's needed. And I'm talking elite level sport where that player is almost a commodity, so need them to be fit. At other levels, I've recently worked with a skier that used a new brace technique. Let's say new, it's been around a couple of years, where she had a complete rupture of the ACL but did not want surgery, and she'd been braced 90 degrees in a brace for a number of weeks. Everything is knitted together perfectly. We could prove that on an MRI scan. So there's alternatives, is what I'm saying. It's not straight, hate the term under the knife, it's something that patients seem to always know what that means though. It doesn't mean automatically surgical intervention, because it depends. If something is so catastrophically damaged, that patient probably will need some sort of reconstruction, as we call it, of the ligament. But if we can get them better without the surgery, I'll prefer that.
And it often,
but it depends what their circumstances are. If I'm dealing with somebody elite and they need to be playing, they'll probably have surgery.
But either way, don't ignore it. Don't push through it.
No,
get some assistance.
I think this is the thing I constantly say to patients. We all have aches and pains, don't we? If people bank holiday weekend have been in the garden doing that DIY, everybody does. It's probably quite normal to have a lower back, bit of discomfort, or a bit of pain on your legs if you've been squatting, gardening. But if people have that pain a week on, why is that pain not going? We're looking at something else, aren't we? And actually, to be fair, you'll know when you even have a class 1 ligament injury most of the time, because it's going to be sharp. It's going to be sharp pain. It's uncomfortable. It's
very different to a general ache and pain.
Yeah, it is, yeah.
Okay, well, we've got some questions coming through already.
Oh, okay.
I think we've touched on the first one anyway, but I'll ask it because Laura sent it in. When is surgery needed for a ligament injury?
In my opinion, only when all other areas have been exhausted, i.e. your treatment, they're not responding. You know, and again with this, it'd be lovely if we had the luxury of having someone MRI'd every few weeks. Just to see how that's knitting together. What we have to look at is the way the person's moving, whether their range of movement isn't as excessive. So we have to work on it in that way. But often, I mean, going back to skiing, when people injure knees in skiing, it can be really catastrophic. And I've seen people that have injured 3 out of 4 ligaments in a knee. They're going to struggle. There's probably going to have to be a surgical intervention there. And of course, don't get me wrong, I'm not demonising surgery. But, you know, evidence for some of it's very good around ligament areas, and some of it, sometimes that patient, I'm afraid I've worked with ACL patients, because they're going to graft. They'll say for an ACL injury on the knee, we may take a graft from the hamstring area around the back of the knee, sometimes down here on the front muscle there. And to a point, it will kind of work. It's tough material they're taking to replace the ligament, but it's not a ligament. And there lies the problem. It hasn't got that strength that it had before sometimes. So for me, it will be building up all of this here. It will be building up all of this here for a shoulder to try and stop it happening again. But if you said to me, can I guarantee it won't happen again? And to the shoulder, a good point with surgery, often when somebody is having repeated dislocations, they're going to have a procedure. Because ultimately, remember, when something is moving excessively, we know your risk of osteoarthritis goes up massively, hugely. If things are moving excessively, we're going to keep gnarly and grating on that cartilage. So somebody with repeated dislocations in shoulder areas, repeated giving way of the knee, which is both scary and dangerous for the patient, because for certain people, they'll become a full risk if their knee keeps giving. So when it's at that level, But
there's no black and white response. Everyone's different. Every injury is different.
But it is. And also, actually, you have to take your patient's view into consideration, don't you? We can only really advise. Some people will be very anti-surgery. Some people, because of maybe having a good response to a surgical procedure, will go, I want the op. Have the op then, and then I'll work with your post-op and we'll get you strong again.
There's options.
There's
options. So Mel said, can ligament injuries heal fully, or will it always be weak? That's a good question.
Oh, that's a hell of a question.
I'm guessing a lot of these answers is going to be, it depends.
Back in the day, we'd have said you're probably going to have a problem. Okay, I think that's when we were not so good on our rehabbing side of things, and possibly wrapping the patient a little bit too much in cotton wool.
Okay.
And not getting them to rehab so much, and relying more on just treatment rather than rehab. So there is a danger, as I said, with the reconstruction when you've had the injury. But if Mel's thinking, if Mel's got a minor ligament injury at the minute, which means she's always going to have it, no, she certainly won't.
Okay.
She won't. It will heal. It will heal. And it doesn't mean there's a weakness. She'll always injure.
No more than anyone else.
The only sticking point with that, if it was Mel's ankle, she may have repeated inversions, and that's where you would need some exercise stuff to try and re-engage his ligament to behave properly. Okay, so no, it doesn't mean you're always going to have problems. It's not like the cliche, once you've had a bad back, because that's not strictly true either. I think people just get bad advice, and I think that about whether I'm always going to have a problem is steeped in the past. We know more now about what we can put you through, and actually we know, certainly in the last 10 years, we can overload you more than we thought we could. Obviously not if it's early stage and there's a lot of damage to the ligament. It has to be really graded, from just movement stuff up to strength, up to, some people plyometric jumping exercise, and you'd think that's crazy, wouldn't you, on someone that's been damaged. But in the end, that's what we work towards. So no, there's no reason at all. If someone's told Mel that, they're probably a bit misinformed, to be honest, but it's a good question.
But if you don't look after it, or you don't rehab it, then it's possible.
It is kind of like anything, isn't it? You can't, sometimes you've got to take it on board to do a little bit of something yourself with your injury, and that's what I push my patients to do. You must do your exercise stuff.
There's another question, I think slightly overlaps. It says from Paul, should I rest completely or keep moving after a ligament injury?
Oh, good question again. So depending on the state of the ligament, shall we say.
And what movements you're talking about
if it's catastrophic, say for a knee, we're going to brace your knee, aren't we? We're going to put it in what we call an orthopedic brace, and we're going to make sure you can't move it, because we need it to rest before it sustains any further damage. But even then, we can still get gentle movement going. So most of the time, we definitely can work with ligaments, but sometimes that's working on joints adjacent to the area. So with a knee, I want to engage the muscles of the glutes, the muscles of your bottom, because we know we can protect your knees and your lower leg injuries if we can engage you more here. So there's lots of stuff we can be doing. It wouldn't be gung-ho, just go back and play football, and things like that. But and actually, overlapping again to, with Paul and Mel's previous question, there are football and indeed the odd rugby player I work with that play those sports without an ACL ligament in a knee.
Oh, okay.
They're not in the greater population for being able to do that, but they have worked so intensely on their rehab, the knee's protected.
Possible.
It is possible. It's probably not the right way, but yeah, it's possible.
Okay. Tracy's got a question about the K-laser. Yeah. Does K-laser actually speed up healing or just help with the pain?
Both. It's a massive pain reliever because it's going to calm down these little things. So to get called nociceptors, your pain receptors, but they're very important because your ligaments are full of them, absolutely loaded with these pain receptors. Okay, that's why it's so bloody painful when you injure a ligament. So yes, we get the pain down by calming down these receptors. And as for speeding up recovery, yes, massively, absolutely massively, because it works to get the collagen fibres, which are type 1, your ligaments. It works to get these things put back into that area where they've been damaged. New ones are placed there, okay? And they're placed there in a way where they're not going to scar so much, because if we get scar tissue on ligaments, that's when we can see recurrences, okay? So it's for that point I use it with a little ligament to get them fibres sort of knitting back together. The other thing as well, just to add to that, it will be a natural anti-inflammatory, so we can get rid of don't get me wrong, we need inflammation. That's what comes to an area where we've got damage, say a ligament, because there's good stuff in that inflammation. So actually, we're not doctors, we're not pharmacists, and we cannot advise on whether a patient should take pharmaceuticals. But I'm always a little bit worried when people have just smacked a lot of ibuprofen or something down them straight after an injury, because why is that inflammation gone to that area? Okay. It's got good stuff in it. We need it there for a little bit. Okay. Then it probably overstays its welcome.
Okay.
So that's another myth, isn't it? Yeah. Inflammation. Of course it means something's a little bit naughty injury-wise if you've got serious inflammation. But remember, it's only your body's response to try and heal that area.
I'm sensing we're only scratching the surface of what's possible with the K-laser, so I'm thinking there's probably going to be a show dedicated.
I'd love to talk about it. We've had it 4 years, I think, this year, and it's been a revelation. It's given us a chance, and centering on this broadcast, ligament injuries. I know I can get them better without having to worry too much about, I'm doing a bit with my hands on here and I don't really know how much that is doing, but that's what I've been taught to do. Suddenly, this thing comes along and you're kind of, it's good. But let's not rule out not using hands on. Got to be done as well. Got to be done as well.
In combination.
Yeah, always, yeah.
And, I've, over the years you've been doing it at the clinic, we've had mutual patients and clients who have used it and have said how fantastic it is. You've used it on me to help with my knee injury, so it is a really effective tool that I think a lot of people still don't know it exists, let alone that we've got it at the clinic. Yeah,
it's a shame really. I mean, it's been used in the veterinary road for a long time, and I've had people come and go, I want you to look at my husband's knee because you sent a load of heat into me with it. I'm like, no, it doesn't work like that. And I said, I don't want to be pernickety with you, but it's very important know why it works.
But it's non-invasive and it's pain-free, so...
Exactly. And remember the knitting of together, the natural healing response that is being slowed down because there's been serious trauma to an area with a ligament injury. It will just speed that up. It will speed it up tenfold.
We've got a question from Sam. Why do I keep re-injuring the same ankle or knee?
We touched on that. Yeah. I bet Sam probably hasn't engaged in a lot of rehab without being rude to her. But purely, if we don't get you doing certain exercises, you are very likely to keep injuring because, as I say, that ligament, they talk from here to here.
So that's an important
also
part
down in the spinal cord, they talk from here to here about what we're doing, where we are in space and time, and somehow Sam's ligament now can't really engage properly, but it's really fixable. I'll be frank with you, it's normally done through quite a lot of seriously repetitive, exercise that is not the most exciting, but it does work. The more you do it, it will re-engage. Or she may have that lax ligament that is no longer as tough as it was. I'd like to have a look at that because I think the longer it goes on, people think they're always going to have it. And every time she's doing that, the risk of an arthritic joint is getting there.
Okay.
And actually, if we leave like the laser alone for a minute and go back briefly to hands-on there, one thing to check with Sam, you're too geeky on the bones, but there's a couple of bones certainly that in a violent rolling of the ankle, so turning of the ankle, can move themselves out of position.
Okay.
So that can be the longevity of it as well. So without somebody, therapist, mobilising that joint back in position, everything around that joint is unhappy, and we could laser that joint, but I won't get the full effect with it because that joint isn't in the right position to start with anyway. So that's where the hands-on comes in with the joint as well.
Which might lead on to the next question that Paul sent in actually. Do I need a scan to diagnose a ligament injury? Obviously in a case like that, a scan's going to be quite important to see what's actually going on, but as a general question,
if I had my way, I'd have one every time with a ligament patient. If I had my way, and I know there's different.
Possible, is it?
No, I know there's different feelings about that. I mean, we do often, and it is quite often actually. I've noticed in the last few years, do privately refer our patients for MRI imaging now. Because that's what they're basically going to need, by the way. I know we touched on this last time. MRI is going to be looking at ligaments and more, if we like, softer structures. X-rays looking more at bones. It's not strictly true, but it's the easiest way of looking at it. The one time I would suggest an MRI, if the recovery is really slow or the excessive movement in the joint is not settling. And that here lies another thing as well. You don't want somebody to keep pulling onto a joint. So I won't, this would probably be up for a bit of debate. If I'm seeing somebody a lot with a knee injury, something on the inside of the ACL we spoke of on the front, every time I see them, I'm not testing that knee. You've got to be careful with it. You've got to be careful if you suspect it is somewhere between a grade 2, remember, which is severe, to grade 3, which is a bit disastrous.
Yeah.
You don't want to keep pulling on that knee, trying to get that. So you don't do that quite so often. What you're going to be doing is listen to the patient. It feels more stable. I'm in less pain.
Yeah.
When I get up in the morning, it's not so sore when I put my foot down.
Okay.
All of these kind of cues, rather than if you suspect, but I'll be honest with you, if I suspect certainly a 2 to a 3, the patient really does need a scan, needs an MRI scan on that knee. Okay. That can be difficult to obtain,
but
I know. But ultimately, yeah, I think because of me working more in sporting background, they're always on offer.
Yeah.
And I think I'm a bit like, it's because it's a bit of a problem when you know somebody needs one, but they can't obtain one.
But when you've got it, it's valuable.
We can still work with it, but it's not ideal.
Okay, well...
Because you want to know what's going on, don't you? I mean, purely, the patient definitely needs to know what's going on with them. And I need to know what's going on with them because I need to make sure they're having the right treatment. I need to make sure the rehabilitation exercise is good. So that's why I do gently nudge people towards scans, which I know is not everyone.
It'd be optimum.
Yeah.
Joe, we've rapidly run out of time. So for anybody who's either struggle with ligament injuries or suspects they possibly could have one, have you got any kind of parting advice, guidance, or anything you want to share with them before we wrap up today?
Yes, I think really, certainly if you've got swelling and you're in a lot of pain, we need to have a look at that. Because there is a lot we can do. And just, again, you never know whether people have had bad occurrences of treatment where they've been balding. We won't do anything like that. We'll assess the injury, and we're all equally as good as that at the Ashgrove, actually. We'll assess the injury and we'll get you on the right treatment path and the right rehabilitation path. And the only thing I would ask is that you have to work with us on the rehabilitation. You must do your rehabilitation. Your success rate blossoms and goes rapidly down if you don't do that stuff on a ligament.
Okay.
It'll get lazy. It'll get used to being how it is.
Yeah. So. Brilliant. Well, it's been really interesting, Jay, so thanks for sharing that with us. That's all we have time for today. I hope you found this interesting and helpful. As always, if you need any advice or assistance, as Jay said, just get in touch with us here at the clinic.